Welcome to the Laughter Clinic podcast with comedian and suicidologist Mark McConville, bringing you practical, evidence-based self-care strategies, the latest research in mental health, along with conversations that inspire, educate, and entertain. This is the Laughter Clinic podcast with your host, Mark McConville.
Hi, my friends. Mark McConville here. Welcome to this episode of the Laughter Clinic podcast. Really appreciate your time in tuning in. This week's guest is the incredible Sue Murray, who is the practice leader of the Zero Suicide Institute of Australasia. So Sue's got some wonderful insights into the future of suicide prevention in Australia and where we're at. And we caught up last week at the National Suicide Prevention Australia conference in Sydney. So we're going to unpack that, what the conference was like, and also talk about her career, which has been incredible. 10 years at the head of the National Breast Cancer Foundation of Australia before moving into suicide prevention. So, yeah, we've got a lot to unpack, and Sue's incredibly giving of her time and her knowledge. So I'm very appreciative of that. So as always, my friends, like I said, appreciate your time in tuning in. If you haven't already done so, hit the follow button and leave a comment or share it with some friends and family, whoever you think might benefit from this material. So, content warning, we do discuss the topic of suicide and suicide prevention in this conversation, so listener discretion is advised. So that being said, please welcome, my friends, to the Laughter Clinic podcast, this week's guest, Sue Murray. Sue Murray, welcome to the Laughter Clinic. Great to see you, and happy Friday.
Thank you, Mark, and great to be here.
So we've got so much to unpack today in relation to, your incredible work with, not only the Breast Cancer Foundation and your work in suicide prevention, but before we unpack all of that, all of our guests get asked the same question right at the start, which is centered around the saying, laughter is the best medicine. And so this is a saying that's been around for over 3,000 years, and now we're in the position where we have modern day research supporting the physical benefits of laughter and the psychological benefits of using your sense of humour as a coping mechanism to help you deal with life's challenges. So when you hear the saying, laughter is the best medicine, as someone that has worked across two incredibly intense fields of endeavour in relation to breast cancer and suicide prevention, what does that saying conjure up for you?
Well, first thing I think of is I wish I could tell a really good joke.
You wish you could?
Wish I could. I am not a funny person, and I don't try to be funny, but because that very adage, laughter is the best medicine, you sort of think, I wish I could come up with that thing that makes something right at the right time for the right person. But I don't even try, Mark. I don't even try. Maybe to one of your laughter clinics.
Well, look, it doesn't have to be a joke as such, even if it's just, a sly comment when you're, amongst your group of friends and your people, your tribe, because I'm sure, we've all got those people in our lives that we can share a laugh with, that share our similar sense of humour. So who would those people be for you in your life?
Well, I've got a university friend who could just tell you what time it is and it would seem funny. It's just one of those people who've just got that great timing, that great sort of output, and it makes you laugh. And then I've got another friend who's got the happiest laugh.
Is that
it's
right?
A really happy laugh. And I love hearing her laugh. And I have to say, my husband does a very good job of making her laugh.
Is that right?
Yeah.
So he's the funny one in the household?
In the household, yes. I give all the comedy credit to him, right. Not me.
Okay. Well, look, what a career that you've had in relation to, spending, what was it, a decade or so at the head of the National Breast Cancer Foundation, and then moving over into the field of suicide prevention. So, you know, they're such hefty, you know, fields of endeavour, Sue. Like, well, okay, so let's start with what led you into the Breast Cancer Foundation as the head of that, and what did that transition look like going from there into suicide prevention?
Yes, so my entry into the world of the National Breast Cancer Foundation came via work I had previously done with the Cancer Council in New South Wales. And at that time, I worked with a truly wonderful woman who has remained a mentor for me right throughout my career. Elaine Henry was really an exceptional leader. And so Elaine was aware of the National Breast Cancer Foundation, having been really the architect of it initially when I was at the Cancer Council, and the position at MBCF became available, and I applied for that. And I guess one of the things that I think is important to say is that serendipity has played a much greater part in my career development than any specific planning has. You know, I'm one of those people who, if opportunity presents itself, I'm ready to give it a go. That's just something that's innate within me. And I think when I look back at the Breast Cancer Foundation, there were two of us in the organization when I started, and the revenue or the turnover was less than $1 million. And I left it 10 years later with about 35 staff and $20 million turnover in
Wow.
1 year. And really that was taking advantage of every opportunity that came our way to generate more funding for breast cancer research, and then to use that funding to put new ideas forward in the research world, and really try and encourage people to come up with innovative and ways that weren't necessarily being explored by the traditional Commonwealth government funded research. Being independent of government meant that we were far more able to be flexible in the type of funding that we were able to offer. And I think that led to some really nice developments in the world of breast cancer research, treatment, and support over the years. And the transition was an interesting one. So I had worked for a couple of years after leaving MBCF with the George Institute for Global Health. They wanted to set up a foundation. And for me, this again was another expansion. It was looking at a global environment and having an opportunity to contribute there. That was only a short-lived appointment. I got 18 months, and then the owners of the directors of the George Institute felt that the foundation wasn't delivering in the way they wanted to, and so I was made redundant. And that was a really interesting time in my life, because it made me just sit back and think, what did I want to do? Because I have never not worked. Never.
Yeah,
I've
right.
always worked. And so the biggest decisions I had to make that day weren't about how am I going to keep a roof over the head of all my staff? How am I going to keep food on the table? How are we going to make advances in knowledge about breast cancer, faster, deeper? All those things disappeared. And I just had to decide, well, what are we going to have for lunch today? The biggest decision I had to make. And it was really quite open, invigorating, I think, just not having that level of responsibility. And so I potted around in the garden for a little while, and then I felt ready to step back into the world of work. And so I applied for the role of chief executive with Suicide Prevention Australia. Now, this was an organisation at the time that needed rebirthing. It needed a whole repositioning. It certainly needed to get a stronger financial base. And so what I had realised was that my real strengths are in growing something. My real strengths are not in managing a big organisation. It's about, being there in the moment, determining that we've got a way forward and pushing forward with that way. It doesn't suit everybody, but it suits me, and it sort of feeds my my need to grasp opportunity and lead with it. The really interesting thing for me on those coming from breast cancer and previous to that, the Cancer Council, when I stepped into Suicide Prevention Australia and I went to the conference, the first conference that I delivered, and there were, I think, just under 200 people at that conference.
Wow. Isn't that amazing?
Yeah.
And
When
what year would that have been, Sue? What?
So that was 2012, I think.
Okay.
If you think about it, last week there was 1,100
It's
people.
incredible, isn't it?
But sitting at that 2012 conference, just before I officially started with SPA, I sat there and I could hear so much of where I thought cancer control had been 20 years ago. And suddenly I thought, this is not going to be hard. Yes, the content is different and I have to learn a lot about that. But building this organization is what we have been doing, increasing our knowledge, increasing our understanding, increasing community response to this issue is nothing new for me. And so I really use that experience of the National Breast Cancer Foundation as a foundation for how I could see that we could shift the dial in regard to suicide prevention. And believe you me, at that time, the dial really did need shifting.
Yeah, it's incredible to, like you said, to go back and think of, a conference where there's 200 people. And, what's that, 14 years ago? And then last week, the conference in Sydney, which we will get to, we'll unpack that in a little bit greater detail. One thing that's happened along the way for you, which I think is incredibly cool, is when you were honoured in the 2021 Queen's birthday honours, and you got your Medal of the Order of Australia for your services to the community, which is, we've got people listening from all around the world, this is a big thing in Australia where, it's a national recognition for outstanding services to the community, and yours was specifically for, your services to breast cancer and suicide prevention. So when you got that, call or letter, like, how did it come through for you, and what was that like that day for you?
Really, you need to have probably tens of thousands of people standing up there with you.
Mm.
It's a real shame to me that it's one person that seems to embody this award, but in fact, it's only because of the tens of thousands of people who have supported and believed and been engaged in what you and your team are doing.
Mm.
And anyone who works in the community, I know, says the same thing. This is not about what I have done.
Mm.
It is indicative of the tens of thousands of people who have done so much to help us move the dial, whether it's on breast cancer, whether it's on chronic disease, whether it's on suicide prevention.
Mm.
It's an incredible honour to think that someone even took time to make that nomination. Um, you know, that's very kind. It's
Mm.
very kind of a person um, to do that because it takes a lot of work. You're not supposed to know, or you don't know that the person's doing it. They have to gather all this information about you. I did find out who did the nomination, and she spent a long, long time talking to a lot of people to get the information that ultimately resulted in the OAM. And I am very proud of what I've done, but I know that it's not me who's done that work. It's all of those people who I had the privilege to be working alongside.
Mm.
Um, and all those thousands of Australians who got behind the activities of MBCF and now are getting behind the activities of FPA.
Yeah. Yeah, it's the collective effort, isn't it? You know, like you're the figurehead at the top of it, but it's, you know, it's like the iceberg, you know, you see that, but then underneath that there's so much that goes on behind the scenes that, like you said, there could be quite easily 10,000 people up there with you over the years.
Yeah.
Um,
And
so-
remember, Mark, you were one of our very first ambassadors, if you remember, for SPA.
oh, right back there, 2012. Yeah, where were we? Down at Coogee? No,
2013.
was it Coogee?
Yeah,
Where were we? Yeah, Coogee.
was it Coogee?
Yeah.
And then from that, you became an ambassador for FPA.
Oh, look, it is. I never in my wildest dreams thought that I would end up working in the field of suicide prevention. That's for certain. And the like you said, the people around you, like you must see similarities between the people that are drawn to work in breast cancer and breast cancer research, and the people that are drawn to work in suicide prevention. You know, it would seem like it would take a similar type of person to be driven to work in these fields.
They are, and I think within all of the community-based organisations, there is always a very strong element of lived experience, whatever that experience might be. It's the personal drive that people have to want to make the world a better place,
Mm.
and I think that's my underlying driver. I want to make the world a better place. And, if I do just a little drop in the ocean to make that, then I'm very pleased.
Well, you've probably overseen a shift in the way both of these things have been looked at from a population point of view in Australia. You know, because I
Mm.
know we're very much into the early intervention and early screening for breast cancer, and all that is prolific now. You know, it's
Mhm.
almost the accepted thing. So, do you see that suicide prevention is kind of starting to do that shift as well?
Most definitely I do. Most definitely. And I think back to the early days of breast cancer, when people, and cancer generally, when people did not want to talk about it if they had a diagnosis, where the awareness within the community was very low key. And, when I think back to 2012, the work that Lifeline does with their Out of the Shadows walks, the work Beyond Blue has done with that very specific brief of raising awareness in the community, Living Works and the training that they do. All of these organisations, Are You Okay? And the ability they've had to build up community confidence to be asking that question, and then not only asking the question, but stopping and listening
Hmm.
for what people say. All of these organisations are really helping to raise community levels of comfort in terms of speaking about suicide and its prevention. And that can only be good for the
Mm.
community. It's the sort of thing that removes the stigma. I can tell you, when I started at breast cancer, there was an ad that an agency had done for the organization, and it showed the upper torso of a woman's body with her mastectomy scar. And there was absolute outrage at this ad. And oh my God, we can't have that out in the community. We can't possibly, men would say, I don't want people to know what my wife looks like. And, there was a real negative sense. Fast forward, we've got the Mother's Day Classic coming up on Sunday, which has raised millions of dollars for breast and ovarian cancer research. But there'll be people running down the street with the bras on the outside of their shirts and, really overt support for that issue. And I think, that's where I guess we I'm not trying, I don't want to be insensitive here, but it's that level of awareness that really destigmatizes the issue. And that's something that we've really got to continue to work on, because it is that stigma, whether it's self-stigma, whether it's stigma from the community, whether it's stigma within the health system. We have to alleviate that level of stigma that prevents people from seeking out the support and the care that they need.
Mm.
Because suicide is the result of, a sense of overwhelming and not being able to do anything about it. And it's a moment in time. And you and I both know that if we can interrupt that moment in time, we have the opportunity to prevent a potential death.
Mm.
And that's a really important thing, because that individual has so much more to give to the community. So, it's removing that stigma that helps people feel just to be able to sit comfortably with a person who is feeling very high levels of distress.
Yeah. Yeah, it's interesting that you mentioned. I think one of the most damaging types of stigma is the self-stigma, that we put, we've got societal stigma and all that, but when you put that on yourself, we learn about how it compounds your suffering, because it impedes recovery, because you're unlikely to, put your hand up to say, I'm struggling, I need a hand here, you know what I mean? And
Exactly.
so I think a lot of the education around that is, it's okay to not be okay and all of that sort of stuff. It's, especially when I go out and, I spend a bit of time doing work in rural farming communities and all of that. And it's hard, that Australian stoicism out there in rural Australia is still very, very much a thing in the male community, in the male farming community. And so breaking down that self-stigma that, you know what, mate, it's all right to be, unraveling at the fact that you've got all of this stuff going on. It's to be expected. It's part of it.
Yes. Yes. And of course, isolation becomes a big part in those rural communities.
Yeah.
And the more you become, in those levels of distress, you're likely to withdraw and withdraw and withdraw. And that's where those points, that I just said, you become overwhelmed at that moment in time. So, yes, it is something that we really need to help the community and individuals within the community to have that level of comfort, that level of confidence that they can open up and that there will be support available for them.
Mm. Yeah, it's a lot of it's, the voice of lived experiences. That's one of the things that I think has made such a massive difference just in the time that I've been, involved in the suicide prevention sector. It's really, it's entrenched in everything to do with suicide prevention now, isn't it?
Yeah, and that was another area, that really my experience at breast cancer really helped me support, when SPA first set up their Speakers Bureau. I had come out of breast cancer, while I was funding breast cancer research, the Breast Cancer Network Australia was also formed just around the same time. And that was an advocacy group of women who have been impacted by breast cancer, whether they themselves have been diagnosed, they had lost someone to that diagnosis. And, I had seen they had changed the way the health system was looking at the diagnosis, management, and support for breast cancer. And there was lots of players in that as well, the health system players as well, and the researchers. But the voice of the women was so impactful. And so and I pay full credit to Jo Riley, who was working with me at suicide prevention at the time, to her work in really supporting or driving, if you like, SPA's leadership around the engagement of those with lived experience. And then off the back of that, organisations like Roses in the Ocean formed. And really, Jo Riley was the architect, I think, of really emphasising the importance and the value that individuals with lived experience can bring to the suicide prevention. And it's interesting now, working as I do with the Zero Suicide Institute, the whole Zero framework is designed to be co-delivered between the healthcare leadership and the lived experience leadership. And I see health services very willing and wanting to engage with the expertise of those who have been users of their systems, but only to a point. Health is a very risk-averse environment, and sometimes the expertise that comes forward brings some really important changes that could be made in the system, but the system itself is very averse to making some of those significant changes. So sometimes I think the voice of lived experience gets frustrated that systems don't move as fast as they would like them to, but I would encourage those voices to not be quiet, for those voices to continue, because change can happen. Change does happen, and it makes a huge difference to the community.
Oh,
ultimately.
yeah. Well, and it also makes a difference to the people themselves who are using their voice.
Mm-hmm.
It's not only beneficial to, others. Like, I've got a couple of close friends of mine who have, lost multiple, unfortunately, family members to suicide, and they've taken it upon themselves to, become speakers and advocates, and just seeing what it does to them, how it lifts them up and feels as though they can contribute in some way to this. That aspect of it as well is incredibly important.
I think, having a sense of purpose. It boils down to having a sense of purpose.
So talking about sense of purpose, right? So let's dive into zero suicide for those people that may not be familiar with the Zero Suicide Institute of Australasia. So talk us through what it is that you guys do, and I love the 7 elements because I think that's very cool how they all interlock together. So talk us through that, Sue.
Yeah, so I was fortunate enough to attend an international meeting of the Zero Suicide healthcare framework. And it really struck me that there is so much in suicide prevention that we need to consider. And to where could you make the most difference? And there are a lot of organisations that are working at the community level. And I looked at the framework, and its focus was the healthcare system. Now, the healthcare system is a very defined environment. And so I thought that is a place where we could really do make a difference. We know that around 1 in 5 people who suicide have been recently within our health system. We don't necessarily know the other 4 in 5 and where they've been. So we have a thing called Medicare. It means we can identify those individuals who present to the health system. Therefore, we should be able to care for them, keep them safe, and have them well supported when they leave the healthcare system. So I felt that this was perhaps a place where I could make a difference in an advocacy sense. And the framework itself is really not rocket science. It's about good leadership. It's about ensuring you have trained staff who are confident and competent to work with people who present with suicidality. It's about making sure you're collecting data that helps you understand who is in your catchment, what do they need, and what are the sorts of things that we as a health system can be doing to alleviate whatever those pressures are within the context of our health system. Then it's about ensuring that those people who are working within the health system, and whether they're clinical or non-clinical, those individuals have confidence in themselves to be able to meet with and respond to an individual who may be presenting with in suicidal distress. Remembering that there are times when the person will enter the health system and the first person they will see is an administrative officer, not a clinically trained expert. And so it's vitally important that we are able to give all of the people who may come in contact with someone who is suicidal appropriate training that commensurate with their role and their responsibility, but gives them the confidence to be able to work with that individual in whatever capacity they may meet them. And so the first 3 elements, we talk about building the capability of the organisation. And then the remaining 4, which are identify, engage, treat, and transition, are about the practice changes that are needed to ensure that the individual and their support networks are well supported for recovery. And that's really what the framework is. Those 7 elements are about reducing the suicides or attempted suicides within our healthcare system. So we are very much complement to the wider community-based suicide prevention initiatives of some of the other organisations I've already mentioned. But the healthcare system needs to be prepared and capable of meeting the needs of those who present. And one of the things that has stuck with me from very early in my time at Suicide Prevention Australia was one of our lived experience advisory committee members saying to me, I would never go back to the health system. Now that's an indictment on our health system. We should not have people who say, who make those comments. We want the health system, and the health system itself wants to be able to support that. So that's why I moved out of Suicide Prevention Australia and came into the Zero Suicide Institute of Australasia to really advocate for improvements to the healthcare system so that we're ready and able and capable and comfortable and compassionate enough to work with people who are suicidal.
Yeah, it's a lot to digest, isn't it? Because the big thing is, like, if you look at it from a resources point of view, it's pretty fair to say that the mental health system in our country is fairly under-resourced, isn't it?
I think that's definitely the case. The health services that I work with, when they spend not days, not weeks, but months trying to fill a position, that we know that There's a limited number of clinical psychologists. The mental health workforce is severely underserved in our community.
Do you think that's the biggest challenge that's facing the mental health sector in Australia at the moment? Is like the staffing and the training?
Workforce shortages. I think it's a very major problem that the sector is facing, and particularly as we start to see these other important initiatives which are focused upstream. So in New South Wales, they have the safe havens or the suicide prevention outreach teams, the safe spaces in Queensland, the safe I think the safe haven in Victoria as well. The urgent mental health care centres. They're now called the Medicare mental health care centres. But these are all new initiatives that also require trained people to be working with them, whether they're a peer worker or whether they're a clinician or whether they are someone who is in an allied health field. But they still need staff, being staff. And, our peer workforce, which is gaining traction, still needs to be built. So even as we open these alternatives to emergency departments, which is what we're trying to relieve the pressures there so that those who do need to be in the healthcare system are able to be dealt with quickly. Our alternatives to, the hospital system also need to be staffed. You can't have an open door and nobody there ready to receive them because it's that connection that helps the individual. It's that immediate connection with someone who is able to sit and be with the person as they seek to de-escalate that level of distress.
Yeah, and the training aspect of it is what really, excuse me, has really surprised me, or should I say the lack of training for our health professionals in relation to suicide prevention and risk assessment and that kind of stuff. Like I was reading a article recently where there's a lot of the individual states in the United States are campaigning to have suicide prevention training mandatory for their GPs. And as we know, a lot of the time people have seen their GP prior to a suicide or an attempted suicide. Yes. And, we've got a system in the moment where it's like 60+% of Australians that are suffering with mental health conditions aren't seeking professional help due to cost and cost of living barriers and that sort of stuff. And I've really been surprised over the years, the lack of suicide prevention training for psychologists. So, they get to their master's level in doing a psychology degree and they've had minimal training in suicide prevention, which I just find inconceivable.
Exactly. I think that's exactly right, Mark. And I think about, the undergraduate training and the fact that you very often hear, either I had no training or I had maybe we did a lecture on it. And the, health professionals are lucky if they can remember. One of the things that it's part of the implementation of the Zero framework is to look at the workforce survey and understand what levels of training people have had. And it's a very stark reminder of the lack of specific training in suicide prevention. So yes, we have very well trained and highly capable mental health clinicians, but very often those clinicians have had no direct training in suicide prevention. And so that whole concept of asking the question doesn't come easily. Are you feeling suicidal? Do you have a plan? Those questions are not coming easily without having had some training. to be able to ask those questions.
Mm.
And so, yes, even at the clinician level, let alone how do we build our peer workforce fast enough to be able to meet the demands of, our those centres who are trying to move away from the medical model and have very much um, an open door and a lounge room style approach to being able to help people de-escalate in moments of distress. There's
Oh,
there's a
it's
big there's
yeah,
a big hole to fill,
yeah,
Mark.
oh yeah, and it's one of those, that's why, because as you know, I'm closely associated with ACERAP and Jacinta Hallgood,
Mm,
and
yes,
that's why it's so encouraging the work that they're doing not only in the research space but in the education space
yes,
and the training space. It still amazes me that ACERAP and Griffith is the only place that you can actually get postgraduate qualifications in suicide prevention and
yes.
suicidology.
It is quite, but I do remember Jay Liskian from Every Mind at one point telling me that the challenge with the university curriculum is it's by university, by university, by university. So it's not like in the school system, and I do have to say in my first life I was a school teacher and I did work on curriculum development. So I know that we can create one curriculum in the high school education system and it goes across all schools.
Mm.
That does not happen from what I understand from Jay Lee in universities. And so, um, that level of training, which would help a lot in the destigmatization as well within the health system.
Mm.
The stigma that people experience within the health system, it would help a lot
Mm.
if there was something in those undergraduate curricula
Mm.
that actually help individuals in their pre-service training.
Yeah, yeah. Yeah, 100%. Well, that kind of leads me into I want to have a bit of a chat about the conference that we were both at last week, which was the Suicide Prevention Australia National Conference.
Mhm.
And, like you mentioned before, you've got over 1,000 people. They have about 1,100 delegates.
Yes.
Firstly, before we get into unpacking the conference content itself, what was it like? You've been to this conference numerous times over the years. What was it like for you to sit there and see that many people now to come together nationally for this conference? It must be quite rewarding for
Well,
you to see how this is.
it was a sense of pride for Nevis Murray and her team at
Mm.
Suicide Prevention Australia, because I think Nevis, in the time that she's been leading the organisation, has really elevated the quality of policy work that Suicide Prevention Australia, the advocacy
Oh,
work
the
that they're
advocacy is
doing.
brilliant work, isn't it, that they're doing?
Yes, yes. I think the organisation has come ahead in leaps and bounds. And so I had a real sense of pride for Nevis and her team
Mm.
in delivering that conference because I do know how demanding it is. And I think I noticed, I might have been on her LinkedIn post or something like that, that she said, here we were on the Friday afternoon having a debrief to get ready for the 2027 conference in Hobart.
No.
So, and that's exactly what it is. It's a year-round work to be able to put on an event like that. And I think it's they should be very proud of what have been able to achieve and the growth that Suicide Prevention Australia is enjoying in its membership. At least I hope all those people are members of SPA.
Yeah. Well, that's the first conference that I've gone to in a long time. So how did it compare for you to previous conferences like recently? And I know they had a big one in Perth last year.
Yeah. So I think the quality of I've definitely seen an improvement in the quality of the conference overall. I think also there was some real effort, I thought, in this conference to put some provocation out there to
Mm.
challenge people and their thinking, to not let the status quo prevail, but to really push the boundaries. And I think a few of our plenary speakers did that.
Yeah, well, around the, I noticed that when it came to the conversation around AI and chatbots and that sort of stuff, I found that quite interesting. Was there, I was thinking about it the other day. I was trying to put it all into a LinkedIn post, and I'm like, oh, I've got too many takeaways from the whole conference. Was there something for you, in particular, like a presentation or a speaker or like something that stood out for you personally?
Well, I think although it's something that he's been talking about for a very long time,
Mm,
I thought Professor Ian Hickey
mm,
and his discussion around the need for reform and for that reform to be based around regions
mm,
and around needs of regions so that you're working with a smaller, geography, you're working with a smaller cohort of people. Um, it is good to have our national um, strategy, but that national strategy has to be interpreted on a contextual basis. And so I found I really enjoyed the way that Ian unpacked his views around how you could reshape the system to be much better and deliver in a much closer place to where people are, not expecting them to have to travel, ad infinitum. I think so. That was one. Um, we were discussing this yesterday on our Trans Tasman Zero Suicide Healthcare Alliance. We were discussing the conference, and someone reminded me that the human rights panel was also a very interesting
mm,
panel discussion. Um, and the other, I did too enjoy the discussion, the last discussion around the social media and the use of AI and chatbots and all those sorts of things. I thought that was an interesting one. The way that those major platforms and their parent companies are trying to do things to ensure the safety of users on their platform. And I reckon they've got a really tough job,
oh,
and they
yeah.
will always fall short. There
Mm,
will always be examples where things go wrong. But it was good to hear the panelists speak about the efforts that those organisations are going to improve the way they do monitor and support individuals
mm.
um, on their platforms with suicidal distress or with any level of distress.
Mm. I would have liked to have seen a little bit more conversation around that, to be honest, at the conference in relation to AI and chatbots, and that's only coming from because recently I've had a couple of instances where I've been doing my own research for the podcast and stuff, and I've found that in India at the moment, they've got 500,000 adolescents, 500,000 adolescents are using AI chatbots
Mm.
for as an early intervention first port of call because the country is they basically got
Yeah.
hardly any psychiatrist that is trained in specific adolescent mental health.
Mm-hmm.
And it really, one thing in a research in a paper that I saw, the headline read AI generative chatbots establish a therapeutic alliance with an adolescent in under 5 days. And I remember seeing that and thinking, well, that's a pretty lofty claim. Where did they pull that from? And so I did a bit of a deep dive and I actually found the research, and sure enough, they've got all this qualitative data from these adolescents saying, I feel heard, I can contact it in the middle of the night, I've got 24/7 access. Because there's a level of anonymity, they're not actually sitting across from another human being. They open up more and all of this kind of stuff. And, it screams caution to me. I really would have liked to have seen more conversation, or like it was, there were presentations about it at the conference, but it was only one or two. Like it wasn't as, I was expecting it to center a little bit more, be more centered than that.
I have a feeling that the FEMS conference this year has got a specific emphasis around AI. So it's definitely coming into, into people's frame of reference, I think, for these major conferences. But
because the reality is it's happening whether we like it or not, isn't it?
Yes, yes. But there is also, as you say, there is that need for caution. In another forum that I've been a participant on, they had discussions with ChatGPT. They had a presenter on ChatGPT who was able to say, this is an example of the limitations where ChatGPT supported the individual's plan for the way in which they were going to take their own life. This is a good plan, is what ChatGPT said. So, that's completely the other side of the coin. So that's why you're right. We really do need to, move forward with this, but with a degree of caution.
Yeah, and the other thing that and it kind of circles back to what we were talking about previously, is the gap in education for our GPs, our frontline, primary healthcare professionals, and our psychologists in relation to their level of suicide prevention training and awareness. I don't recall seeing anything like that mentioned at the conference, and I think that's a really big part of what we need to be talking about in this sector.
Yeah, well, make sure that you do the feedback form for Suicide Prevention Australia.
Yeah, I will be. I didn't want to do it straight away. I wanted to sit and digest everything. But to me, that seems to me it just seems like a no-brainer.
Yeah, I think someone said to me a long time ago, and I think this was a very, very, it's always stuck with me, and that is every piece of evidence came from someone's idea. And we get a little bit hung up on the importance of evidence. And we know that from the work looking at how long it takes for the knowledge to translate into practice, that 17-year gap which the Lancet published some years back now. I think the big challenge, of course, is that technology advances at such a pace that our poor research world can't possibly keep up with that. So the idea of that, evidence informed becoming a much stronger part of the way in which we let programs and services be developed, I think, we have to go with that, because we can't wait for this huge amount of time for something to become standard practice. I think for a GP, they've done 6 years of medicine, then they do however many years it is for their GP, to belong to the college. It's years and years and years before they get an opportunity to actually be out there in the community. And there's nothing within their curriculum that helps them be equipped for work with people who present with suicidality.
Yeah. And yet we know that, the research tells us that, people see their GPs,
We do, regularly.
Yeah. So let's talk about the. I wanted to chat with you and get your thoughts on the National Suicide Prevention Strategy, because that was mentioned at the conference as well. The
Yep.
Australian National Suicide Prevention Strategy. What is it? 2025, 2035, I think it is. So where do you see zero suicide fitting into that framework as well?
Yeah, so I'm very encouraged by the national strategy from the zero suicide framework context, because prevention element I think is critically important, and I think it's very positive that we've got that focus on prevention. But then, as I've been saying, we've got the support component, which is about how does our system actually work to ensure the people who present are supported and treated and discharged most appropriately. So I see the support component of the national strategy aligning very well, or zero suicide aligning very well with the support component of the strategy. And then also with a number of the enablers. When you think about the importance of data within the framework, there is also the importance of the data as being an enabler for programs and services under the banner of the strategy. So I'm very encouraged by the strategy, and I see that the work that we do in the zero suicide healthcare approach aligns very well with those elements of the strategy.
Mm. Yeah, it's so, like, as you know, I'm very much a fan of the going down the social prescribing aspect as well, fitting into the National Suicide Prevention Strategy as well. And it was encouraging that last year the federal government funded a feasibility study into creating a social prescribing framework for Australia, which is, for those that don't know, it's something that's big in the UK that's happening right now, being funded under the NHS. And it was interesting that there were certain elements of the feasibility study into social prescribing that actually align with the National Suicide Prevention Strategy, and they actually highlighted in the document. So I think, where does that sit with you, like the social prescribing aspect of it, and this non-clinical approach to helping prevent suicide?
So my passion in life is keeping well people well. So that's the short answer to say it fits very well with me personally, Mark. Irrespective of my role in suicide prevention, just generally, I have always been someone who wants to keep well people well. So the idea of social prescribing is very much aligned to that prevention end of the spectrum. So keeping well people well, getting to them before, finding those other avenues within our society that we know have a benefit to individuals who are in distress. And so helping our primary health network, the primary health as in GPs, understanding what social prescribing is, and having the infrastructure for the GPs to then be able to forward on to others. I think it would be something, it fits very well with me. It fits very well with me.
Yeah, it's very much in its embryonic phase in Australia. And so as you know, I've applied for a Churchill Fellowship to hopefully go over to the UK and explore how they do that model at the moment. I'm so encouraged that there is somewhere in the world that comedy on prescription is a thing. Like people can go and do a comedy course and go and be encouraged, A lot of it comes out of the massive amount of people in the UK that are on antidepressants, and now they've got doctors going, well, before we reach for the prescription pad, we're going to suggest prescribe you go to an art class, a music class,
Yes.
a comedy class, or any of that sort. Any social subscribing, bushwalking or whatever it is to get out. And I love the fact that that is actually happening somewhere in our world, and the thought of bringing it back to Australia, if I can have a small hand in that, I'd be well chuffed. But we seem to have a lot of challenges in this country in relation to getting new ideas over the line, though, don't we?
We do. And, you've only got to think back to some of the great inventions of the world, Wi-Fi, the Hillswest Clothesline, all those initiatives that were actually developed in Australia but had to go overseas in order to get the funding for those initiatives to become part and parcel of our lives. Terrible indictment. So
what do you think the biggest challenge would be at the moment, trying to get a social prescribing national framework up and running?
Oh gosh. Well, we do have our Centre for, or upcoming, is it called a Centre for Disease Control? But it has a very prevention focus on it as well. So it will be very interesting to see if that agency actually starts to pick up on these things, because they should be, if they're about the the prevention of particularly chronic diseases, which we know are very lifestyle. So many of them are lifestyle oriented. So the whole thing about shifting the dial around away from the medical focus, as you say, let's not reach for the prescription pad, but let's reach for an initiative that really means something to the individual and help them to get down that pathway. I think what the barrier is probably just this whole thing that we are so hung up on what's the evidence. And I'll just say again, my friend who told me every piece of evidence started from a good idea. I just love that notion.
Yeah. Yeah, I had a podcast guest on recently, Jodie Allen, who's a clinical nutritionist, and she introduced me to the lifestyle medicine, the 6 pillars of lifestyle medicine. And when you think about, like sleep, movement, diet, it's all pretty basic stuff that, that we sometimes just, because we get caught up in our day-to-day lives, don't we?
And, I would say that we have all the evidence in the world to tell us that those things are good for us, and that they have the longevity that one gains by practicing those behaviors over a lifetime. The evidence is there to say.
One thing that I was really encouraged by at the conference last week was the amount of reference to the importance of social connectedness in relation to suicide prevention. And because I'm forever spruiking, the importance of social connectedness and the hidden mental health benefits of sport, because all of a sudden, you've got a jersey on because you're supporting your team, and you're walking through the shops and you see someone else walking towards you that's got the same jersey on, and then all of a sudden you've got that underlying connection of feeling a part of something bigger than yourself. And I was really encouraged how many speakers actually made reference to the importance of social connectedness last week.
Yes. And I think that's one of the beauties of the sort of non-medical environments that we're seeing being created through the Medicare mental health centres, through safe havens, through the safe spaces. All those areas are really built on that premise of helping people connect. And that connection, it's, we often say, if you can just sit with a person who's feeling in distress. Just sit with them for that moment in time. It will pass. It will pass. And so having those centres where people know that they can go and they can sit and know that they will be supported for those high levels of distress to pass, it's because someone is there to connect with them. So yes, I think that's so true. And yes, it did come up on many, many occasions, didn't it?
Yeah, I was encouraged by that. And I was also encouraged by the sense of collaboration, which I found quite refreshing, because that's another thing I find, we have so many people swimming around different parts of the same ocean, for want of a better term. And I remember a friend of mine years ago saying, Australians don't like to collaborate. We're not great collaborators because we're always fearful that someone else is going to get the credit or someone else is going to steal my idea or whatever. And I was really encouraged by this sense of collaboration, that I noticed last week at the conference, and even with just the little stuff that I'm doing. And, if I get a chance to do this Churchill Fellowship, I had, a few people from, just saying, look, we'll help you disseminate whatever research you can bring back and all this sort of stuff to help try and, contribute to the conversation about social prescribing. And, I really was encouraged by collaboration. I thought that was great.
So I mentioned earlier the Trans-Tasman Zero Suicide Healthcare Alliance, and that's really what that's all about. The members are people who are all implementing the Zero framework within their health services, and it's an opportunity for them to come together. We learn from each other, we share resources, we identify challenges, and we find solutions. And one of the presentations that was at the conference last week was a collaboration between New South Wales and South Australia in the design of their suicide prevention pathways, which is part of the framework. And that came out of our Trans-Tasman Alliance. So, the importance of collaboration. None of us have enough resources. None of us have enough resources, but collectively we can have a lot more resources if people are open to sharing and sharing their knowledge and sharing their time and sharing their, as I say, their resources.
Yeah. Yeah, it's so complicated, isn't it? Suicide prevention. It is just one of the most complicated. And that's one of the things, when I'm doing my Laughter Clinic mental health presentations, I just say it is incredibly complicated, because you've got one side of the fence that also, there's still debate that I hear from people that, some people view suicide prevention as a health issue, and then other people view it as a social issue and a societal issue. For me, I think personally, I believe it's a combination of both, but it's just too complicated to even try and pigeonhole it.
Yes, and I guess part of the beauty of our society is that we're all different. And so, it is, nobody is going to present with the same manifestation. Everyone will be different. And that's part of the challenge. We can't deal with a one size fits all, because that's not what it is. It is a very individual thing, but it's helping that individual unpack what works for them. And finding ways that person can find their own agency over time, overcome that level of distress that they might feel.
If you think there's, okay, I'm going to give you a magic wand moment, right? So if you could wave your magic wand and change one thing about the way that the health system as a whole in Australia approaches suicide prevention, what do you reckon would make the most significant difference?
I do think, from what I have seen, the inclusion of peer workers.
Yep. Yep.
And those individuals being part of the care team.
Mm.
And, you know, in the idea of the safe havens came from the Crisis Now program in the US and or the Medicare mental health centres, I should say. They're now being across Australia. So they've adopted the Crisis Now model, which is a peer first, peer last model. So the first person you meet is a peer worker, and the last person you see when you leave the system is a peer worker. And
Geez, how much
there
of
are
a difference would that make?
yeah, yeah. And but that's when you think about all our hospitals. I don't know how many there are. I know there's 1,500 hospitals with EDs, and probably even more EDs because there are lots of little hospitals around. Having peer workers engaged in all of those, that's a massive addition to the workforce. But it's certainly something I know from talking with Tracy Gale, who is also in Queensland and has been a peer worker for many, many years. The difference that she has made to individuals who turned up in the health service that she was working in. They've come back to her many times and said how important it was to them to have met her. But she also was she was strong enough to be able to challenge the clinical directors and the other clinicians to be able to hear her voice, to let her have a voice and let her be part of the treatment team. So I think we've got quite a way to go.
Yeah. Yeah, the workforce is everything. So on the workforce, let's have a think about the people that actually work in, well, not only suicide prevention, but also your previous life in breast cancer. It it takes a certain type of person to work in this field, and then you've got to look at the ways that it can take its toll, on people personally that work in challenging fields like cancer and suicide prevention. So what would be your message to anybody working in this field in relation to making sure that they find a way to look after themselves? And how have you managed to do this, Sue? Because you've been at the forefront of this for a couple of decades. Like, how have you managed to keep a perspective on it to look after your own mental health while you've been dealing with such hefty stuff?
I often say to people that I have rose-coloured glasses.
Is that right?
I see the world through rose-coloured glasses, and I'm an eternal optimist.
Yeah.
I know, that we can always do better. But I think one of the things for the workforce that is not helpful is that our health system still has a very blame-oriented culture. And this was my presentation, very blame-oriented
right,
culture.
gotcha, yep.
And this was my presentation at the conference. It was about restorative justice and learning culture and the importance of shifting away from this blame orientation when some sort of adverse event, whatever it may be, occurs within the health system. The first person generally is, or very often, is the person closest to the incident at the point in time it occurred. And there is very little consideration given to what the circumstances were that the person was working in at that point in time. And so the restorative justice and learning culture is shifting away from that blame orientation towards and punitive responses to negative events to one where you're focused on healing, recovery, and learning. Really, to achieve that, the health system leadership at the very top of the hospital system has to have a very different approach to the way they want the culture of their organisation to evolve. Um, and that, I think, is one of the biggest challenges for the workforce, that we really need to shift, particularly for the suicide prevention workforce, in the health system. We need to shift away from punitive responses to those healing and recovery focused responses.
Mm. So if someone was listening and they were thinking that they would, want to be involved in suicide prevention and start to, be involved in the sector, whether that's from a lived experience point of view or a professional point of view, a clinician or someone that's, thought I'm going to focus on suicide prevention now, what would be your advice to that person coming into the field now?
I would certainly encourage them to do so if they thought it was right for them. But
Mm,
as I said, I'm an opportunist. If some opportunity comes my way, I would certainly encourage individuals who feel that they would like to work in this area to do so, to find a role that suits them and that delivers them the satisfaction of knowing that they're contributing to the well-being of individuals who experience extreme levels of distress. But that's me.
mm,
Like, I am a person who wants to help other people. So I think it is something that people need to think about very carefully,
mm,
because not everybody has my rose-colored glasses. Not everybody has the level of optimism that I do. And so I think it is very important that they examine within themselves how they might react
mm.
in a particular role within this environment.
Yeah, 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 because it's not for everybody, and that's fair enough because it's, it's rewarding, but it can be pretty hefty, So given your rose-colored glasses and your optimism, what is it like right now after having just been at the because I know I came away from the conference and I was all inspired and, it's pretty powerful to be amongst that many people who are all focused on preventing suicide and you think to yourself, wow, the sector is pretty what's unified, I suppose, is one word to look at it, or healthy. If you've got 1,100, I think that was the biggest attendance they've had at the conference, which I
Definitely.
thought was pretty cool. So what is it? What is it right now that gives you hope? With your rose-coloured glasses and your undying level of optimism.
Yeah.
Where do, what's giving you hope right now in suicide prevention?
I think that I'm now meeting people who actually want to do something, who don't want to sit back and um, and experience grief. It's generally, I'm meeting people who really believe that they can make a difference, that they can make a change. And so I think that gives me a lot of hope. I think the national strategy, if we get an implementation plan,
Yeah,
gives me a lot of hope.
yeah.
Um, and, the leadership across the suicide prevention sector, the non-government suicide prevention sector, I think that leadership is it's strong and it's relatively stable.
Mm,
And so that, I think, is very helpful, that
mm,
you've got people who know what's gone before, so we don't have to reinvent the wheel. And you've got people who are seeing change happen as part of their organization. And that, I think, is a very good thing. So I think the leadership of the non-government suicide prevention sector is a big positive for us in Australia.
yeah, 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 it's cool. Yeah, I thought the same as you. I thought Neve must have been very proud of seeing
Yeah,
that conference come together. And I know,
yeah,
she's obviously got a big team around her that help pull it all together. But at the end of the day, I could, I actually tried to have a chat to her a couple of times, but she was just so busy. Every time I went to have a talk to her, she's got someone with
yeah,
her.
yeah,
But yeah, I thought she must be very proud to see that come together the way that it did.
yeah,
And,
yeah.
so
I was
many,
very proud of it.
yeah, nice. Well, Sue, you have been so incredibly generous with your time and your knowledge. I am so appreciative of it. So we have a tradition here at the Laughter Clinic podcast where we finish up our chats with the Feel Good Five. So Sue Murray, these answers can be as long or as short as you like, and so let's get to peek behind the curtain, so to speak. So, as we wind this up, and like I said, I'm very appreciative of your time and your sharing your knowledge with us. It means a lot. It really does. So, on the Feel Good Five, first things first. Number one, what is it that makes you happy?
Oh, puppies.
Puppies. Everybody loves puppies, right? We're actually babysitting a couple of puppies at the moment. They're pretty needy little buggers, I got to tell you.
Yeah, they're very cute. Very
Yeah, I am.
cute.
Yeah, how could you not like puppies, right? Okay, number two on the list. What are you grateful for today?
Oh, I'm grateful every day for the family and friends that I have in my life.
Nice. Yeah, other people. Beautiful thing to be grateful for. Number three on the list. What are you looking forward to? What's coming up?
Mm, Well, I'm presenting at the European Symposium on suicide, prevention of suicidal behaviours. And as part of that, I'll be travelling through Lithuania, Latvia, and Estonia. I'm
Wow,
looking
that's
forward to that.
exciting. So
Mm,
when is that conference?
That's in August. In
Okay.
August. Yep.
Um, and whereabouts is the conference itself being held?
In Lithuania.
Well, I actually think I've got a colleague going to that. I'll have to get her to make sure she reaches out to you. How
Yeah.
exciting for you. Have you ever been to
Yeah.
those countries before?
No, no, not at all. So
Wow.
very different part of the world. I was sitting with um the team from ASRAP at at the dinner at the
Mm,
conference, and we were talking about Estonia
yeah.
with Kyrie.
Yeah.
Kyrie
Wow.
Paul.
Oh, yeah.
Mm,
Well, yeah. Well, as far as things to look forward to, that's a cracker, I got to tell you.
yeah, yeah.
Okay, number four on the list. What is your me time when when you feel like switching off from the world and just having a bit of a, chill out and recalibrate? What's your me time?
And I really tell you this? Go for a walk. That's a safe one, isn't it?
Walking.
The not so safe one. The not so safe one is I have a bath with a glass of wine
There's nothing
and
wrong
I
with
just
that.
sit there and
Hey, you wouldn't be alone. You wouldn't be alone in the amount of people that go, yeah, well, that's pretty much as good a me time as you're going to get.
yeah,
You
yeah.
know, nice one. Okay, and the last one on the Feel Good Five is what's made you laugh recently, Sue?
Gosh. Uh, See, Mark, done a pretty good job. I had a few laughs with you today. So that's my most recent.
Really? Oh, well, that's very
Yeah.
kind of you to say. I got to tell you, I had a few good laughs at the conference, even though it was a heavy conference to be at. I thought it was nice where they had the screen of the lived experience speakers coming up and saying that, even though we're here to, it's a suicide prevention conference, don't feel as though you can't, enjoy a moment of laughter with your
Yes.
fellow delegates and that. And I thought that was really nice of them to add that in
Mm.
there.
Mm. Yep.
Yeah.
Very much so.
I had a few good laughs at the Life Awards, I will say, It was a good night, that. All
Yeah.
right. Well, Sue Murray, thank you so much for your time. As I said, I really appreciate it. And yes, well, that's very exciting about you heading over to Estonia for that conference. Will you be? I'm heading down to the Moral Injury Conference in a couple of weeks down in
Oh, yeah.
Tasmania. Are you
Yeah.
heading down for that?
No, 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 no. I've
Well, you
got
can
a
only
couple
do
of
so
other
much,
projects
right?
got a couple of other projects on the agenda.
Yeah, nice.
You know.
Nice. All right. Well, like I said, thank you
Thank
very
you,
much for your
Mark.
time. And for those of our friends that are listening, as always, if you like the episode, hit the follow button, share, subscribe with someone who you feel as they may benefit from this type of content. And no matter where it is that you're listening in the world, please be kind to yourself and be kind to those around you. I'll talk to you next time. Thank you very much, Sue Murray.
Thank you, Mark.
Thank you for listening. The information contained in this podcast is for educational and entertainment purposes. It is not intended, nor should it ever replace, advice received from a physician or mental health professional. Want more info? Visit thelaughterclinic.com.au. If you enjoyed the episode, please share and subscribe. Thanks again for listening to the Laughter Clinic podcast with your host, Mark McConville.